advocates, and partners from Asia and the Pacific, Eastern Europe and Central Asia, Eastern and Southern Africa, and across the different regions gathered in one shared space this afternoon. We are at a decisive moment for the global HIV response as countries work toward the 2025 targets and prepare for the 2026 high-level meeting on ending AIDS. The new global AIDS strategy offers an ambitious rights-based roadmap. Also, as we look ahead to the 2026 high-level meeting on ending AIDS, gatherings like this one becomes even more critical. The commitments that will be made at the high-level meeting will shape the next phase of the global HIV response, and it is essential that the PLHIV voices guide what those commitments will look like. This convening this afternoon presents an opportunity to collectively unpack the strategy, reflect on the shifting political and funding landscape, and articulate what communities truly need for commitments to translate into action. It is also a moment to strengthen alignment across regions and elevate a PLHIV-driven voice that can influence policy, shape implementation, and safeguard our rights and dignity. We are very much honored that we are joined this afternoon by our colleagues from the UNAIDS Global Office and UNAIDS Regional Offices. They are the leaders who are deeply engaged in translating the strategy into regional realities. Their insights will help us understand the programmatic shifts, the structural barriers that persist, and the opportunities for PLHIV-led advocacy to remain central as countries move from strategy to action. As we move forward to this convening, I'd like to welcome our GNP Plus Co-Executive Director, Florence Riaco-Anam, to kindly set us the scene.
Thank you, Enad, and thank you, everyone. Good morning, good afternoon. As I see Larissa is here from Australia, good evening to you. Distinguished colleagues, partners, leadership from UNAIDS at global, regional, and national level, fellow people living with HIV, leaders, advocates, and everyone else gathered here today. Thank you so much for joining our March 2026 GNP Plus People Living with HIV virtual convenings. We started these convenings last year so that we could come together and reignite our leadership on matters that affect us, particularly in the development of the global AIDS strategy that is now finalized, launched, and we will be speaking about today. We also did so to think ahead how we would engage in the high-level meeting planned for this year. So today, in the usual community leadership style, we are here to turn the page of this global AIDS strategy to action, ensuring that it does not remain words on a page, but becomes a lived reality in our lives as people living with HIV and the many affected by HIV worldwide. Huge thanks to you, Anjali, for joining us this early. I truly, truly appreciate it. To you, Anne, Imon, Bridget, and anyone else joining us from UNAIDS. The collaboration between GNP Plus and UNAIDS to anchor our work ahead in this strategy is not only important, but urgent as we begin to plan for the high-level meeting on HIV and AIDS, where a strong member state political declaration will set the pace for this strategy's implementation. I've been asked to set the scene and I was asked guiding questions. So I will try to do that, to share what this truly means for us as people living with HIV leaders and for the communities we represent. First, what does the strategy to action mean for people living with HIV in relation to the global AIDS strategy? I believe this strategy is the foundational blueprint for our collective HIV response, especially now with a lot of uncertainties and everyone trying to find ways. This strategy provides clear guidance for all of us right now. It is an opportunity to galvanize political commitment, bring back the energy and the effort to our joint multilateral response again. It has established shared measurements for progress through ambitious targets and indicators. I'm particularly excited about the metrics that are very clear for all of us to get by and behind. We aim for 40 million people living with HIV on treatment and virally suppressed, 20 million people accessing ART-based prevention, and all people accessing services free from stigma and discrimination, ultimately reducing new HIV infections and AIDS-related deaths. At its heart, the strategy has three, I like to call them ingredients, for sustaining the response beyond 2030 and achieving the HIV epidemic control: country leadership, community leadership, and HIV integration. Country leadership calls for resilient, nationally owned responses with sustainable domestic financing and integration into broader health systems. Community leadership positions communities, especially people living with HIV networks and key populations, as central drivers, shaping policy, delivering services, monitoring progress, and holding systems accountable. HIV services integration embeds HIV services into primary healthcare, universal health coverage frameworks, and multisectoral platforms to make more accessible, efficient, and resilient health service delivery against disruptions. So this strategy offers clarity on the essential role of people living with HIV and communities most impacted by HIV in addressing the unfinished business of the epidemic. It recognizes that our lived experience is not just valuable, it's indispensable, especially now in the times of adaptations in our health facilities, in our financial structure, and in our policy development and processes. So communities must lead the way in advocacy, service delivery, and accountability. The strategy actually states there is no success for the global strategy without a concerted effort to support community-led responses. So this brings me to my second question. How can we ensure that the global AIDS strategy becomes a lived reality rather than a technical document? We, as people living with HIV, must understand we are at the core of the success of the HIV response. When we all, people living with HIV, access treatment and achieve viral suppression, we don't just gain quality of life. We embody U equals U, undetectable equals untransmittable, and drive down new HIV infections, hugely impacting the ambition of the HIV epidemic control. In this next phase, the 5 years of the new strategy, the response is facing major shifts, particularly in funding and health systems that are prioritizing country ownership, integrating HIV into primary healthcare and UHC frameworks. Amidst funding uncertainties, which we are already feeling and experiencing, and other crises across the world. These changes demand adaptations. They demand adaptations to us too, to our role and to how we will engage with the work ahead. Our role as service recipients must also align with these adaptations. So using the opportunities in the next 5 years to transition, we must ensure we firmly have our space identified, institutionalized, and resourced within health systems, particularly at the primary healthcare level, where our interventions will be needed the most. We must continue to provide, through our real life, insights on what works, what pinches, what needs rethinking in this adaptation to ensure services reach all of us who are impacted by HIV, and we leave no one behind. To be effective, we must first ensure widespread awareness that this strategy is here and it exists, what it contains, and what concrete opportunities are open for our meaningful involvement, from self-care, community-led monitoring, and social contracting to institutionalizing our representation in national planning. That's why this gathering excites me, and I'm excited that UNAIDS is collaborating with us on this, because we will then be informed and we will listen and collaborate alongside with each other on the work ahead. Together, I believe we can bridge the gap between global commitments and on-the-ground impact. I look forward to the discussions today and to the powerful actions we will take ahead together. Thank you, and back to you, Enad.
Thank you so much, Florence. I just want to remind everyone that we have translations for this webinar. We have Vietnamese and we have Thai translation. And we have also enabled the closed caption tool. So if you want to see the captions in your language, you can just click on the caption icon below. Again, thank you so much, Florin, for setting the scene and for setting the floor for a productive discussion this afternoon. I'd like to call the UNAIDS Deputy Executive Director, Anjali Akikar, to deliver the opening and as well as to present the Global AIDS Strategy 2026-2031. But before we go to the presentation, I have some few questions to Anjali, to have uh, uh, for her intervention. How is UNAID supporting countries to operationalize the strategy shift toward integrated person-centered service delivery? How can global and regional partners work together to safeguard civic space and ensure that PLHIV networks and PLHIV-led interventions remain central to decision-making and accountability? And what is one strategic shift that could accelerate progress and protect HIV responses in a time of shrinking civic space and rising inequalities? Anjali, we are very much happy to have you here. The floor is yours.
Great. Thank you so much, Inad, and thank you so much to GNP Plus, Florence, and Sibongile, and the entire network. We are so grateful to partner with you now, before, now, and into the future. Your role, as you said, Florence, your role convening together is really the core and the bridge between what we have as the global AIDS strategy and bringing it to life at the country and community level. So thank you for kicking us off today, and thank you for working hand in hand with us as we move into the future. Inad, let me take a stab at responding to the questions that you've just asked. And before I do that, I just really want to thank everyone for joining today. Thank you from all the regions that have joined, and thank you for those who joined yesterday from the other regions of the world as well. I know we're doing this globally. So I think Florence in her opening remarks really set the stage well. And we'll go into the details of the strategy, the global AIDS strategy, momentarily also. But you asked that I reflect a little bit on how UNAIDS is supporting countries to operationalize the shift toward integrated person-centered service delivery. And so let me start by reflecting there. First, it's really spaces like this that are essential to ensuring that people living with HIV, those affected by HIV, are shaping and leading the way on the implementation of the strategy at the country and the community levels. I want to begin by recalling that this global AIDS strategy is really the result of your extensive input and consultation through the process, bringing together people living with HIV, communities, governments, civil society, private sectors, others across the region. It really does reflect also on the growing inequalities, the human rights challenges, and uncertainty. But it also presents a real opportunity to end AIDS and ensure that we can sustain those gains, the response into the future. So, reflecting on what it is that we are doing to really ensure that this operationalizes, integrated person-centered care. What's different about this strategy, unlike the current or the previous strategy, is that this really shines a light on what needs to happen at the country and community level to sustain the response into the future. And what's implicit and explicit in sustaining the response is ensuring that the HIV response is integrated into all health systems and broader social and financial and community systems. And that this is strongly linked to primary health care and the broader universal health care framework that Florence also noted. This framework, this global aid strategy really puts integration and sustainability and anchors integration and sustainability in the global aid strategy. And one thing that I just want to reiterate as we go through the session this today is that as we think about integration, we from the HIV response, from the movement, and from the services, we have to ensure that integration does not mean dilution of services. Integration must protect the strengths of the HIV response, all those things that has made it work for impacting the lives that are here today. Differentiated service delivery, peer support, treatment and prevention literacy, community outreach, safe spaces for key populations, community-led systems, community-led monitoring, community-led delivery. All of these pieces that are critical to the HIV response must be so that's what shines a light on how we do that. One thing that we're doing to specifically operationalize the global AIDS strategy is really work together with you at the country and community level, together with the Global Fund and the US, as the Global Fund rolls out its next grant cycle 8. And work together with you as the US government rolls out their bilateral memoranda of understanding and the implementation plans. The strategy absolutely aligns to these other processes, including the sustainability roadmaps that the countries have been engaging on and that are setting the foundation for many of these Global Fund and US partner government bilateral agreements. So the strategy really, it continues to be the North Star or the foundational blueprint, as Florence noted, for all these other processes. And so it's absolutely aligned. So part of bringing the strategy to life is really aligning all of these processes and making sure that we're collectively moving together. You asked, Inad, that I also reflect on how global and regional partners continue to work together to safeguard civic space and ensure that PLHIV networks and PLHIV-led organizations remain central to decision-making and accountability. And here I'll just say that as Florence noted, there are 3 central ingredients or pillars of the global AIDS strategy: community-led responses, sustainable responses, and people-centered care. And again, this community-driven responses, this is the focus of ensuring that we have to stay connected from bringing the global strategy from a piece of paper to reality at the regional and country levels. Where shrinking civic space and funding constraints and inequalities continue to exist, the absolute core that we need to make sure is embedded, institutionalized, resourced, and really the focus as we move into the future is community-led responses. And these are led by you, people living with HIV and others that are affected by HIV and AIDS. So again, the strong global and regional partnerships are essential to sustain the political commitment, mobilize resources, advance the standards, and strengthen the accountability of what we seek to achieve in the global AIDS strategy and the targets that are associated. One thing that I want to note is that as we move toward the high-level meeting in June, we as UNAIDS, we are committed to ensuring that meaningful engagement of civil society and communities occurs throughout the entire high-level meeting process. so that the next political declaration reflects lived realities and protects the core elements of the global AIDS strategies. We have launched this week the call for nominations for the multi-stakeholder task force that will play a critical role in the preparations for the multi-stakeholder hearing and the high-level meeting. And we count on strong participation of people living with HIV networks in all the stages of this process. And we can answer some more of those questions if they come up later. The final point is you asked about one strategic shift that could accelerate progress and protect HIV responses in this time of shrinking civic space and rising inequalities. And I'll just say here, and I'll go into more details of this as we present the global AIDS strategy, but I think the shift that's really key here and what's dramatically different about this strategy versus the previous strategies is the very explicit focus on sustainability and what that means. That shift and what community leadership is as a part of sustainability is at the heart of what this global AIDS strategy is all about. And so that shift from what what the strategy was before around really accelerating and increasing scale up of interventions, which again, there are gaps that the strategy outlines that we have to continue to close. But what's really distinct about this strategy is that focus on sustainability and what it takes to sustain the response. And community leadership is core and central to that. So with that, I'll stop there. Inad, as just some opening reflections, but really excited to be here, really excited to share more about the strategy and next steps. Back over to you.
Thank you so much. And maybe we can now share the global AIDS strategy.
Sure, I'm happy
Yeah.
to share my screen if that works,
Okay.
and
Okay,
or
that
unless
works.
you've got the slides.
I got the slides ready.
Okay, great. Then I'll just
Okay.
go with what you project.
Okay. Thank you so much, Anjali, for the reflections on the opening. And I think now this is the time to unpack the global AIDS strategy. Over to you.
Terrific. Great. Thanks so much. So really excited to present this in more detail to you. I'll try to go fairly quickly just in the interest of time. And if we could then just move to the next slide. Sorry, are these the slides?
No,
These might be slides from yesterday.
for West Africa.
Yeah. Sorry, Inad, you might be on mute.
Sorry, I think it's better if you share your slides.
Okay, no problem. Give me
Yeah.
just 1 second.
Sorry, Anjali, I have the slides. It's Clayton here. If you want, I can also
Sure.
share from my end
Okay.
if that's helpful.
Sure. Thanks, Clayton.
Let me do that.
Okay, let me make Clayton host. Okay, great.
Just go to the folder. Sorry. Okay. I hope
Terrific.
you all can see. Yes.
Great. All right, let's go ahead and get started and go into the weeds, if you will, of the global AIDS strategy. So first, why are we here and why it still matters? In this world where we are in right now, it is consumed with all kinds of conflict, crises, human rights erosion, political uncertainty, and some are quietly asking whether ending AIDS is still possible, whether it's still realistic, whether it's still a priority. Our answer to that is a resounding collective yes, absolutely. Ending AIDS is still possible, but it's only possible if we do not give up, and it's only possible if we move together as a united movement as we approach 2030 and beyond. That's why we do need a strategy, because the world, not because the world is calm, but because the world is turbulent. And as I noted earlier, this is not a UNAIDS strategy. This is a strategy for the world. It's a roadmap. It's the North Star, grounding our work and showing what it will take to end AIDS as a public health threat by 2030 and ensure that responses are sustained beyond. On the next slide, please. So we're really at a historic crossroads here. The science exists, the tools exist. Communities have never been more resolved, but political will and financing are fragile. And this very well may be our last window of opportunity that we have. With significant resources coming in through the Global Fund, through the US with the bilateral agreements, through country governments themselves. So the strategy is not about maintaining the status quo or the systems that currently exist. The global aid strategy is about transforming them and what is needed for the future as we move into that together. It's not about incremental change, it's about decisive action. And it calls on all of us, governments, donors, civil society, communities, leaders, to choose courage over fatigue and hope over resignation. This is our moment to set the course for the next 5 years that we will never have again, where all of these processes are aligning and converging together. And so the strategy comes at the most opportune time. Next slide, please. So just a word about how the strategy was built. It wasn't built around behind closed doors. It was shaped by you. It was shaped by thousands of other voices across regions, across identities, across sectors and experiences. It came from people living with HIV, young people, key populations, governments, donors, researchers, parliamentarians, UN partners, and all others. It came about through voices heard from surveys, from consultations, from regional dialogues, from virtual consultations, from deep lived experience conversations. You helped shape it, you stress tested it, and you strengthened it. And what we have now represents that collective voice. Next slide, please. It's based on 4 building blocks. The strategy has been developed on these 4 what we call building blocks. The first is a midterm review of the current global aid strategy, or the current global aid strategy before this new strategy takes shape. It was the midterm review of really where we are against the 2025 targets, which have now since expired. It also was built on the recommended global AIDS targets for 2030, which are now our established global AIDS targets for 2030. As I stated earlier, it was built on significant consultations with countries, civil society, experts, private sector between March and October of last year. And finally, it was built on the sustainability roadmaps that are currently being developed and implemented in countries around the world. Next slide, please. And the global aid strategy, this is kind of it in a nutshell, or the ingredients, as Florence said earlier. The global aid strategy starts with the people. It's a strategy for 2026 to 2031 that invites collective recommitment and ambition to end AIDS by 2030 with these 3 critical pillars or ingredients. The first is country leadership for sustaining inclusive multi-sectoral HIV national responses. The second, reducing inequalities and upholding people's right to access HIV prevention, treatment, and testing services, including for women and girls, men and boys, children, key populations, affected or at risk of HIV. And third, it involves community leadership at all levels of the response. Next slide, please. There are many components that are new from what currently the current global AIDS strategy has and what the new global AIDS strategy has. And here's just a depiction of what that is. And I'll just quickly move through some of this. The new global AIDS strategy is not business as usual. It responds to the evolving world we're in now, where we're going, widening inequalities, new health and economic shifts. And it's not only what's new is not only the framing, but the level of ambition as well. It has a sharper focus on addressing the inequalities that still exist, the gaps that still exist in the response, whether it's in structural barriers, whether it's in services, but around the people who are most left behind. It has a deeper commitment to human rights and gender equality and decriminalization. It has a stronger commitment to communities as leaders and decision shapers, and it focuses better on integration with broader health and development agendas, including universal health coverage and preparedness for future crises. It has clearer lines of accountability, who must do what, by when, and with which resources. And it has a strong focus on the metrics. In short, it's a strategy designed not to just sustain progress, but to close those gaps that still exist and ensure sustainability as we move into the future. Next slide. And again, these are just the priorities of the strategy that I just noted, on sustaining the response, on people-focused services, and of course, community leadership. Central to all of this is ending inequalities that continue to persist and inequities that persist through the response. Next slide, please. The strategy aims to be more focused and prioritized. The last strategy included 15 areas of action, 10 priority areas, and 5 cross-cutting. And what the new strategy presents is 8 result areas. These are result areas from financing to HIV prevention, and you'll find actions that aim to build sustainability of the response, ensuring full community leadership and strengthening community and country systems and health security. So I won't read through all of these, but here are 3 of the priority areas as well as the 8 result areas. Next slide. Again, I'm not going to read all of this, but under priority 1, this is really around focusing on financing, systems integration, and data. And here, there are specifics around what it takes to finance the response, what it takes to integrate the HIV response into national and community systems, and what it will take to ensure strong data and information systems are preserved and critical as we move into the future, including community-led monitoring. Next slide. This is the second result area focused on integration of the HIV response into national systems. And here, really just to note that this involves investing in capacity building of health services. It involves embedding a human rights-based approach to strengthen integration of HIV services with stigma-free, gender transformative, and youth responsive and key population appropriate services. Next slide. And these are further details on what it takes to strengthen strong data and information systems. Again, I don't want to read through all of this. You have it here, but as I stated earlier, strong data and information systems are absolutely essential and critical to community or to the basis for the response. Next slide. Here is result area 4, and this is really focused on recommendations for scaling up essential HIV prevention, testing, and treatment services, but also on how to improve delivery of those services. And this is a real intersection between biomedical, structural, community, and behavioral options for HIV prevention, which is result area 4. Next slide, please. Here on result area 5, we're ensuring available, accessible, acceptable, and quality HIV testing and treatment and care for people living with HIV. I want to reiterate here that it's absolutely critical that we ensure the role of networks of people living with HIV, affected by and at risk of HIV, in the design and implementation of programs, including treatment programs, to meet the needs of those who need them the most. Next slide, please. Here on result area 6, this is about ending stigma and discrimination and upholding human rights and gender equality in the HIV response. Again, details are provided here, but again, really absolutely critical that we ensure that services are stigma and discrimination free in order to ensure that everyone has access to the services that they need. Next slide. Here we have result area 7, which is around equitable access to scientific, medical, and technological innovations in HIV prevention, testing, and treatment and care. And here, we know that there are current innovations that exist, like lenacapavir, for instance. But I want to also reiterate that that when we talk about innovation, it's not only about technological innovations, but it's also around innovations of service delivery. How do we see innovations in service delivery by communities, for example? How do we use technology and AI to facilitate service delivery? So innovation is not just about new technologies, but it's also innovative delivery of services. Next slide. And finally, result area 4, and this is absolutely critical, which is around the pillar of community leadership in the response. Here, this is all around strengthening community leadership, around institutionalizing community in the response, in all aspects of the response, in coordination and decision-making mechanisms. This is about formally recognizing and institutionalizing communities in the co-development of policy guidance, reform policies, regulatory frameworks. It's about ensuring communities participating in all levels of the response and resourcing all components of community responses to HIV. It's about social contracting. It's about what it takes to ensure community-led service delivery is part and parcel of the sustainability of the response, including community-led monitoring and research, supporting youth leadership in the response, capacity strengthening of community-led organizations, and really supporting community engagement in the sustainability planning processes as well. So it covers soup to nuts of everything that needs to be part of strengthening community leadership as it relates to sustaining the response. Next slide, please. I won't go into details, but there are 16 top-line targets here, and you'll see them all listed here, with a focus at the right on, by 2030, reducing new infections by 90% from 2010, and continued 5% decline per year after 2030. All also leading toward reducing AIDS deaths by 90% from 2010. And finally, ensuring sustainability of the HIV response. And you'll see the very specific targets and metrics listed here. Next slide, please. Florence mentioned this earlier, but we've streamlined the targets into this very focused approach, which is around the people. This is really to ensure that the strategy will deliver 40 million people on treatment that are virally suppressed, and 20 million people having access to ARV-based prevention options, with all people having access to stigma-free care by 2030. Next slide, please. Just here, reaching the targets will save millions of lives, and we've projected, UNAIDS has done some models to project what this will look like if we can achieve the 2030 targets. It really means averting 3.3 million new HIV infections and 1.5 million AIDS deaths between now and 2030. And that's extraordinary. And that is a commitment we have to deliver. Next slide, please. What's different also in this strategy is that we have included regional specificity for people living with and affected by or at risk of HIV. That's different than what we've done in the past. I won't go into details. I know my team, our team is here, and we'll talk through some of the regional specificity, but that is a really important contribution that this next global AIDS strategy brings to the world, is that regional specificity. Next slide, please. Again, all the regions represented here, including Eastern and Southern Africa, Eastern Europe, Central Asia, Latin America, Caribbean, and Western Central Africa as well. Next slide. And here they're perfect. What's also called upon in this global AIDS strategy is partnership for progress, and that is at the local, regional, and multilateral levels to end AIDS. And so the strategy goes into detail around what it takes to bring all these stakeholders and players together at all the various levels, with a real focus on local partnerships, local action, and bringing that to life. Next slide. One of the pieces that we continue to make sure is communicated is that the global AIDS strategy is part of an accountability system for the HIV response. The strategy itself, as you can see in green, developing this global AIDS strategy is one piece of that accountability system for HIV. What emerges from the global AIDS strategy is what we will collectively work toward this in June, which is the high-level meeting and the political declaration. All countries of the world committing to the targets and to the strategy by this June, that then serves as the basis for the development of the country-level national strategic plans. We then at UNAIDS routinely monitor the targets and the country progress against the targets to really make sure that countries are delivering on the commitments that they have to you, the people that are served in the response, and that countries continue to uphold the promises that they make through the political declaration. So that whole process, which involves this target setting, the strategy, the national strategic plans, and the monitoring that progress, is a critical accountability mechanism to ensure that this strategy is not just a piece of paper, but is actually coming to life and funded and implemented at the country level, and that we as UNAIDS hold countries to account to make sure that they're making progress against the targets. Next slide, please. So just here, just so you have all of it at your fingertips, and I know these slides are accessible or will be accessible to you. Everything can be found on our website, all here in various languages, and more information will continue to be available as we approach the high-level meeting together. Next slide. And that's it. I just want to say thank you. I know I spent a bit of time going through all the strategy, but I wanted to make sure we're all starting from the same page as we move together to implement it at the country and community level. So with that, just to say thank you, and back over to you, Inaid.
Thank you so much, Anjali, for going us through the targets for the priority areas, and for explaining the different targets and how we can achieve ending AIDS by 2030. I think what is special in this strategy is the regional specificity that you have mentioned, and also the different partnerships that we need, particularly the regionalism that we have presented on the slides. And with that, we already have questions in the QA chat box, and I hope you can stay for a few more minutes, Anjali, for us to address these questions later. So before we go to the question and answer, I'd like to let's go to a regional context, and I'd like to call in the floor our colleague from the UNAIDS regional support team in Asia Pacific and ECA, Bridget Quenum, the regional team lead for sciences, systems, and services. In terms of the regional dissemination of the global AIDS strategy in this region, what programmatic shifts do you see, or what programmatic shifts are seen to transition from donor-driven HIV responses to sustainable domestically financed models? What long-term strategies are needed to address structural barriers such as gender inequality, criminalization, stigma and discrimination, which continue to fuel the HIV infections? And how can UNAIDS region governments and PLHIV organizations ensure that integration in the countries within the region is not diluted, or is not diluting HIV expertise or weaken PLHIV-led approaches? Bridget, over to you. Sorry.
Can you hear me, Inaid, now?
Yes, I can hear you.
Okay. I hope it's loud and clear. Thank you, and hello, everybody. It's a privilege to join you today at this event on behalf of Iman Murphy, our regional director for Asia Pacific and Eastern Europe and Central Asia. Iman is not able to join, and he requested me to convey his warmest greetings to all of you. Thank you, Florence, and thank you, Anjali, for framing the discussion so clearly. Anjali has set out the global direction of travel. Let me briefly ground that in what implementation will actually require in Asia and the Pacific and in Eastern Europe and Central Asia. In both regions, the direction of travel is clear. The new global AIDS strategy asks us to move from a donor-driven response to one that is more country-owned, more people-centered, more rights-based, and more sustainable. But country ownership only works if it includes community ownership. Otherwise, we risk calling something sustainable when in practice it becomes less accessible for the people who need it most. The strategy is very clear on this. This shift must include communities and civil society, stronger community leadership, and integration that remains rights-based and people-centered. Let me start by Asia and the Pacific. Across Asia and the Pacific, we are witnessing a convergence of challenges: shrinking donor support, emerging health risks, rising service demands, and persistent inequities that continue to limit access to HIV services. Since 2010, AIDS-related deaths have fallen by 53%. However, we have seen only a 17% decline in new HIV infections, signaling a growing prevention crisis. PrEP uptake remains low with 98% gap. Prevention coverage among key populations is still far below global targets, and many countries remain heavily dependent on external support for prevention. The strategic shift in Asia and the Pacific is therefore not only about mobilizing more domestic financing. It is also about sustaining and scaling people-centered HIV services, recognizing the role of communities in planning, service provision, and accountability, and ensuring that community-led delivery is protected as HIV services are integrated into broader health and social systems. That means the transition has to be smarter. It has to bring HIV services, including community-led services for both prevention and treatment, into sustainable domestic financing arrangements. It has to use social contracting and strategic partnerships so that community-led responses are not treated as temporary add-ons. And it has to integrate HIV with primary health care, sexual and reproductive health, mental health, and harm reduction in ways that expand access rather than dilute what works. Let me touch upon Eastern Europe and Central Asia, where the message is also urgent. This remains the only region where both new HIV infections and AIDS-related deaths have increased since 2010 by 7% and 48% respectively. Prevention coverage remains inadequate across key populations. The lowest reported coverage is among gay men and other men who have sex with men at 34%. The regional chapter is also clear that the response is operating in the context of shrinking civic space, punitive laws, stigma, criminalization, conflict, migration, and disrupted continuity of care. Community-led services and community-led monitoring remain insufficiently institutionalized and financed. In Eastern Europe and Central Asia, one of the clearest problems is the mismatch between the epidemic and the way the response is financed. The epidemic burden is concentrated among key populations and their partners, but the services most central to reaching them, especially prevention, community outreach, and right-based support, remain less secure and often more dependent on external funding. That misalignment weakens prevention, weakens outreach, trust, and continuity, precisely where the epidemic is concentrated. In this region, the enabling environment directly affects whether services can reach people and whether continuity can be maintained. While the two regional contexts are different, the programmatic shifts needed are actually very similar. I will go quickly through, and I have 5 of them. First, both regions need a transition that protects the parts of the response most at risk as donor support shrinks. That means financing prevention, key population programming, community-led prevention and treatment support, and the societal enablers that make services accessible and usable. And we shouldn't finance only the parts of the response that are easiest to absorb into existing systems. In both regions, a sustainable response will fail if domestic financing grows on paper, while the most fragile and most essential part of the response remain underfunded. Second, program shift needed. Both regions need integration that is smarter, not just broader. Integration must go beyond co-locating services. It means people-centered care, where people can access HIV prevention, treatment, sexual and reproductive health, mental health, harm reduction, and other needed services in ways that are safe, stigma-free, and practical. It also means community-led delivery where peer navigators, outreach workers, and people living with HIV-led organizations are not treated as optional add-ons, but recognized as an essential part of the workforce and of accountability. Third, programmatic shift needed. Both regions need governments to move from general commitment to concrete system change. That means embedding HIV in national strategies, health benefit packages, and insurance schemes where relevant, aligning policies, procurement and financing, strengthening supply chains, referral pathways, and data systems, and ensuring that community-led services and community-led monitoring are part of those systems, not left outside them. Fourth, both regions need a stronger response to the structural barriers that continue to fuel new infections and weaken treatment outcomes. That includes stigma and discrimination, punitive laws, criminalization, gender inequality, and gender-based violence and restriction on civic space. These barriers shape whether people can safely test, start treatment, stay on treatment, and use prevention. Fifth, both regions need continuity and resilience built into the response. In EECA, this in Eastern Europe and Central Asia, this is especially visible in the context of war, displacement, and cross-border movement. Asia Pacific also faces displacement, instability, and populations at risk of being missed by more rigid systems due to conflicts in different parts of the region. So continuity of care, flexible delivery models, cross-border referrals where relevant, and contingency arrangements for community-led services should not be treated as exceptional measures. They are part of sustainability. For UNAIDS, government and people living with HIV organization, the ask is therefore quite practical. For governments, it is to finance what the epidemic actually requires, not only what is easiest to absorb into existing systems. For UNAIDS, it is to support countries with the evidence, convening power, strategic analysis, and accountability needed to make integration and sustainability real, not rhetorical. And for people living with HIV organizations, it is to remain at the center of design, at the center of delivery, monitoring and advocacy, because integration that is done without communities will almost certainly work less well for the people most affected. The upcoming high-level meeting on HIV and AIDS is a critical opportunity to anchor these regional priorities in renewed global commitments. In this context, community consultations for the high-level meeting are being organized across both regions to ensure that the voices and priorities of key populations and people living with HIV directly inform the global agenda. Let me make one final point on integration, because communities are right to raise concerns. UNAIDS supports integration, but not a model where HIV expertise disappears into generic systems, and key populations are expected to adapt to services that do not feel safe, trusted, or relevant. Integration must remain voluntary, right-based, stigma-free, and appropriate for key populations. Community-led service delivery and community-led monitoring must be part of integrated systems, and peer navigators, PLHIV networks, and key population groups need formalized and protected roles. But integration is not just about location or technology. It is about systems. It is about aligning policies, procurement, and financing for sustainability. It is about building the capacity of health workers, community actors, and service providers, and it is about ensuring that services are designed with and for the people they serve, especially those most marginalized. Governments play a critical role here by embedding integration into national strategies, ensuring HIV services are included in health benefit packages and insurance schemes where appropriate. Government foster enabling environments for innovation and equity. We must strengthen supply chains, data systems, and referral networks. And we must empower communities, not only as service providers, but as co-designers, as monitors, and as advocates. The test is not whether HIV is integrated on paper. The test is whether integration protects expertise, integration protects trust, integration protects accountability and access. And if we get that right, the strategy becomes real. If we get it wrong, integration becomes another word for dilution. And that is why people living HIV leadership has to remain at the heart of implementation, not at the margin of it. Thank you so much for your attention. Over to you, Ina.
Thank you so much, Bridget, for highlighting the PLHIV leadership at the center of the response to make sure that integration or HIV expertise is not diluted in integration. Thank you for sharing the differences, the different contexts of Asia Pacific and EECA, as well as for sharing the very straightforward programmatic shifts needed. Although both regions have different contexts, Asia Pacific and EECA share these 5 needed programmatic shifts. I will not enumerate them, but thank you so much for those inputs. I am encouraging our participants to ask questions. Please feel free to make use of the Q&A chat box or the general chat box if you have questions, or if you wish to ask your questions on the microphone, please raise your hand. I hope you have time later. Thank you so much. Now, from Asia Pacific and Eastern Europe and Central Asia, let's go to Eastern and Southern Africa. I'm going to call Anne Gituku Shongwe. Good morning to you. Good morning to you. With the context of ESA, what programmatic shifts are seen to transition from donor-driven HIV responses to sustainable, domestically financed models? What long-term strategies are needed to address structural barriers such as gender inequality, criminalization, stigma and discrimination that continue to fuel HIV infections? And how can UNAIDS regional office, the governments, and the PLHIV organizations within the region ensure that integration does not dilute HIV expertise or weaken PLHIV-led approaches? Anne?
Thank you so much, Inad, and thank you to you, Florence, to the whole GNP Plus team and communities living with HIV across the world. And also thank you to Anjali, to Bridget, to other colleagues for presenting and sharing information. I don't want to repeat too much, Inad, because I think our strategies are not that different, but obviously it differs from region. So I'll just try to contextualize it to the region without going into too much detail and just share what we're working on. So I think the first point to make in your first question about really is a question about sustainability. You know, one of the things obviously as ESA is that we are a region that has experienced, we have the heaviest burden of the epidemic. 50% from across the world are living with HIV are from our region. And so, for us, this has been, we have been particularly impacted by the resource shifts in the last year. And so when we look overall at what this means is that we have had to make some some shifts, very strong shifts in support of countries to make sure that the investments that were coming from external partners would be picked up by countries. So last year, we worked a lot with countries to look at what new models of domestic resource mobilization would look like. You heard that we already had started work on sustainability roadmaps. These are roadmaps that we initiated in support with countries and with communities in many countries in 2024. So we started even before we saw the disruptions in resources in 2025. So countries had already created a vision of their perhaps a bit more incremental increase in domestic resources, assuming a particular model of what the change in resource mobilization would look like. I mean, in resource provision would look like from external partners. That shifted. And as we know, countries went about developing new models. And so Tanzania, for example, that we were working with, we developed a tool that we called the Rapid Assessment Financing Tool, RAFT. And that tool was shared with countries, and countries very quickly were able to look at the resources that were available for them and see what the implications were, what they needed to shift around, how they could then develop resources from their own pockets to be able to actually fund the work. So we saw countries like Tanzania picking up the model from Zimbabwe, learning from Zimbabwe and saying, okay, we could actually pick up a model now and build an a health levy. And so they initiated a 3% health levy, of which 70% is going to HIV investments. And this is a country like Tanzania is a country that was 90% dependent on external resources. So the RAFT tool that UNAIDS and we both at the regional and global level supporting countries were able to start making some of these shifts. But of course, the story has continued to get more and more complex. And so we have worked very closely. We created these sustainability roadmaps. We had part A, which was really focusing on the vision. We're now working on part B. This part B is really about getting the vision of domestically led and domestically financed HIV responses and health responses in general implemented, and these are the plans that are being made. So there's a roadmap for how are we going to actually move to domestically led resource process. In fact, just in the last 2 days, yesterday and the day before, we have brought together 8 countries, and we had over 100 people in this meeting representing different parts of government and partners and ourselves to really look at what are the sustainability implications right now. Just last week, in the last week, global fund allocation letters have come out. Governments have signed new agreements with the US. And there has been obviously this sustainability roadmap work. So we established these peer learning webinars where countries are able to learn from one another. How do we actually build for sustainability? How do we make sure that as we do so, we're not leaving communities behind, that the issue of prevention is not a choice between treatment. When we had the disruptions last year, it became a choice between treatment versus prevention based on the life-saving funding. But now in this sustainability part B, we're really looking at how do we make sure that there are real investments that go into prevention, because this is work that is left behind. We still have over 400,000 new infections in our region every year. From 2024 data, that may have even increased more. So moving towards really having a much stronger plan and peer learning and sharing with one another. So this has been a big area of our work. So if I can share those examples, I think that what's been important is to make sure that governments are not having to make choices to fund treatment versus prevention. Rather, how do we fund prevention alongside treatment? Choices to invest in communities, and not only in, to invest in communities while focusing on new health systems, right? So how do we make sure, because as you know, communities have been funded externally. So what our governments continue to prioritize equity even when resources are constrained? How do we make sure that that models of integration do not leave behind the lessons that we have learned over the years in integration, in delivery of HIV? How do we make sure that stigma and discrimination are not normalized in the provision of services? So a lot of this is what we've been working through with governments, and they're quite advanced. We're continuing to provide technical assistance where we have limited resources, but we are still able to provide some resources. So really from a specific sustainability and this issue of domestic resources and the reduction in domestic resources, we governments, I think, are much better positioned and are much more prepared and have plans in place and are working through this, really trying to integrate the different sources of income as they go along. So we continue to work on that. So I think that's in response to your first point. I think your second question about communities, about gender inequality, about structural barriers. I think it's important that for us in ESSA, where we have such a large population of people living with HIV, that HIV is not abstract. It is not a young woman navigating it is a young woman who navigates inequality and risk. It is a key population member who's weighing choices between seeking care and services with dignity. Our person living with HIV being able to ensure that they can access services wherever they are. But what we find is that in several of our countries, there continues to be discrimination and stigma. Just yesterday, I was in discussions with our Uganda team. And in our Uganda team, as you know, there had been this anti-homosexuality bill. This has been a repeated bill that has gone up and down, but we joined the court as amicus curiae to make sure that we are protecting communities as best we can with this law. We are continuing to support that work. We have brought in other investments from different partners to make sure that the work continues. I just use Uganda as an example. Uganda is one example. We continue to work on criminalization and punitive legal environments in several countries. We have a partnership with our Office of the High Commissioner for Human Rights, with UN Women, with UNDP, with different partners across the UN system to really invest in Tanzania. We're working in Malawi. DRC is also part of this program. We've done some work in Kenya. So these are areas of work that we have continued to ensure that we, through these partnerships and through these external partners and working with you, people living with HIV, working with communities who are impacted, key population organizations, that we're able to push back, because we know that there has been immense human rights, gender equality pushback in our region. And so these have been important areas of work. We've been convening LGBTQ communities. We've participated even in countries where we're unable to convene, say, transgender communities. We've worked with other governments to enable us to have convenings of transgender communities elsewhere, so that the convenings continue and the engagements continue. We also have been working very closely with our UN partners and young women's movements on adolescent girls and young women and pushback against gender inequality. And just 2-3 weeks ago, we were in New York at the CSW Commission on the Status of Women, where the resolution 68-1 on women, the girl child, and HIV that is sponsored and led by SADC won. We were able to hold onto the agreements that are made in this resolution, along with partners, Athena Network and other ICW partners, to make sure that the issue of CSW, of the resolution of women and girl child and HIV, is prioritized even in the middle of this pushback that we are seeing. And this is work that we're translating through our Education Plus initiative, through working on Together for SRHR. We've got a big initiative with other UN partners. There's young people's movements. So all of these continue working very strongly. SADC has got scorecards on SRHR that helps to track progress on the provision of services on sexual and reproductive health and rights. So this is work that we do across the board in multiple countries. And I think, just really to say that these issues of stigma and discrimination, of ensuring that structural barriers are addressed, have to remain very central, and central with you at the center of them, because we cannot biomedical our way out of a social problem. We see very, very clearly that while the biomedical solutions are important, in fact, the social barriers are what are going to determine whether or not we're going to break the back of HIV or not. And so these remain important. We have, as you recall from our previous strategy, the 1990 targets. And these are as well as the 30-60-80 targets. These are targets that are to ensure that we're removing barriers to community-led organizations. We're ensuring community-led monitoring is embedded, that prevention remains at the center, but also that community organizations remain at the center of the provision of services. And so those are principles that we want to continue to uphold, and that we continue to work with as part of the principles as we work in the ESSA region. I think on the final point that you raised about integration, and Bridget raised a lot of points in this, and so did Anjali. Integrating HIV into broader health systems is inevitable, and has been a real loud cry from many of our ministries of health. In fact, what we're seeing is quite a bit of a challenge of the models that have existed before, where the HIV work has been in parallel to other health initiatives. But what we must do is to protect and ensure that integration does not dilute focus, or does not weaken the accountability, does not erode the specialized expertise that has defined the success of the HIV response, does not leave out the engagement of communities in the way in which this has operated. So the intention of integration is great, but the risk, if not done properly and not done in a way that actually brings the lessons from the HIV response into the health delivery system in general, is a major risk. And we cannot afford to integrate into a bit of the mainstreaming culture, where we've mainstreamed into disappearance, right? So we want to be sure that we're continuing to pick up the lessons from community-led monitoring, to ensure that we're gathering the data through communities themselves, who are able to track that data and be able to share with governments to see where services can be improved over time. So I think I want to end here to say that the strategy will really, its success is whether we change those lives, the lives of the young women, that prevention remains central, that people living with HIV are able to receive treatment with dignity, that all individuals from key populations can seek care without stigma or discrimination. And we cannot do that without walking this journey hand in hand together. The high-level meeting that we're preparing ourselves for, we need to ensure that with everything, we preserve everything that we were able to achieve with the 2021 declaration, and that if we're able to advance it further, even better. But together, working with your networks of people living with HIV and all the key populations and girls and young women, we know that the success of this strategy is possible. This is not a UNAIDS strategy. This is a global strategy. And we're walking hand in hand together on this. We thank you.
Thank you so much, Anne, for those inputs. Thank you for sharing the different lessons in ESA region, as well as the different work in gender equality, and for highlighting the importance of community-led monitoring and the community-led gathering of data. Thank you so much. Now, we're going to questions and answers. We have a number of questions here. I I'll read the questions and I'll address it to maybe Anjali or to Anne or to Bridget. But the first question is to Anjali actually. Is UNAIDS thinking of developing a plan with community and UNDP to ensure the continuation of UNAIDS strategy, especially 30-80-60? And is GC8 principally fully on board to adopt the 30-80-60 strategy?
Thanks for the questions. And again, thanks all for being a part of this. And this is one dialogue, and we'll continue to stay together on all of these pieces. On the questions related to 30-80-60, again, they are featured in the Global AIDS Strategy, in the targets, because we, as an entire community of people living in the response, working toward the response, working toward the targets, know how critical those 30-80-60 targets are. So, are we going to continue to work together with communities and UN partners on the continuation of 30-80-60 targets? Yes, we will continue to work together. It's part of, you will see elements of 30-80-60 within the sustainability roadmap planning. You will see elements of bringing 30-80-60 targets to life around community leadership in the work that we will continue to do and support. And similarly, around the question with GC8, are we seeing this? Are we seeing GC8 principally fully on board to adopt the strategy? Look, different. We know that different funding mechanisms, whether it's the Global Fund or whether it's the U.S. through the bilaterals or whether it's country investment, we know that that people place different emphasis on different interventions. Our job is to, and why the Global AIDS Strategy exists, is to continue to push the world to the ambition that we know is required to protect and preserve the response and ensure it's sustained into the future. And that's why this strategy is for the world. And that's why it becomes that much more important to ensure that we have a solid political declaration that comes out of the high-level meeting, because that becomes part of the accountability mechanism, right? And so to the extent that GC8 is focused on 30-80-60, that will all depend on how much we can work together with the country governments and the CCMs and the communities as these grants are being put together to ensure that the right interventions are included. So it becomes a job of all of us to work at the country level to make sure that the right interventions are included in both the GC8 grants, but also the MOU implementation plans. And then at a global level, this is where we come together to make sure that countries are politically committing to these targets, as well as the others that are noted in the Global AIDS Strategy.
Thank you, Anjali. I'm just reading through the questions. We might not go through the questions to all the questions, but there's one question here from Tatenda, who's also from Zimbabwe. So I'll address these questions to Anjali and maybe to Anne. His question is, just checking, will UNAIDS consider being a broker in countries where discussions between USG or United States government and national governments have collapsed?
I can start, and then Anne, if you want to come in as well, or vice versa, either way. But great question, and look, that is one of the roles, one of the probably most important roles that UNAIDS plays, not necessarily only with the U.S. government and national governments, but rather that neutral broker, right? a trusted neutral broker between various stakeholders at the country level, whether it's communities, as Anne was describing, and what was happening in Uganda with the anti-homosexuality laws, whether it's different parts of government, health, ministries of finance, justice, social welfare. But again, that is a really important role that UNAIDS plays, is that neutral brokering role. Depending on the country and where, and where we are, yeah, we are continuing to play that role specifically with and between U.S. governments and national governments. There are a lot of sensitivities with these bilateral agreements because they are indeed government to government, and so we don't have a specified role as we would have in the past, where there was a much more inclusive process involved. But I tell you, the national governments are certainly leaning on UNAIDS to play that neutral brokering role, to provide data, to guide where the implementation should be. So we definitely have a role that we're playing, but it varies, and we're inserting ourselves as well because it's a new process. Anne, do you want to add anything to that?
I think really just to add on to what Anjali is saying, for countries like Zimbabwe, Namibia, countries who are still exploring whether to go ahead or not go ahead with those agreements, we have been invited by countries. We're continuing to speak with governments and continuing to speak with the US governments as well. We obviously work very much at the invitation of countries, so we really have to follow their leadership. But we are working closely with them, and in many countries, really inviting us to bring in data, accountability, evidence, so that they're able to make the case as much as possible. So we remain a strong technical partner when it comes to these discussions where there's requests for specific information. So I can't speak right now about Zimbabwe in particular, but I can say that we have been very closely engaged with governments and with the US government in all countries. But we follow the lead of countries also, but we continue to advocate as strongly as we can for all the areas of our strategy to be included in whatever negotiations or discussions are underway. Thanks.
Thank you so much. I think that so there are still questions, but I think we can just take note of these questions and maybe share this around UNAIDS. But thank you so much, everyone, for your time. We have completed, or we have run out of time, and thank you for your generous presence, for your attention, and for listening. If you have any more questions, please send it through us, and then we can facilitate the responses from our colleagues from UNAIDS. And there are questions on the chat, particularly on the call for the multi-stakeholder regarding the high-level meeting. I think Clayton has responded that we will be disseminating it later. Clayton will also share with us, and we will ask our colleagues to also submit applications. Thank you so much. All the participants, all the materials and presentations are available online. Our colleague Anne has put that link on the chat, and I will also be sharing the presentation with our participants. Again, thank you so much, and have a good day, everyone. Thank you so much. Bye-bye.